Great. Well, thank you. It really is a true pleasure and honor to be here at this session. It's been a wonderful morning. I'm going to take us back to hepatitis B, but I'm also going to take us back to clinical patients, but connect that to the intrahepatic discussions that we've had, because I think that's critical, and I'll talk about that a bit as I go forward. These are my disclosures. So I mentioned to go back to the clinic. So this is a patient that I've cared for a number of years, not since she was 3, but I am getting old. At the initial status was e antigen positive high DNA ALT. The historical classification of this patient as immune tolerant really takes into account the parameters that I've shared. E antigen positivity, high DNA, normal LT, and in fact, this individual had a liver biopsy, no inflammation, and no fibrosis. But it did not take into account consideration about what's going on in the liver. How many hepatocytes are infected in this patient? Where is the e antigen and surface antigen coming from? Is it coming from cccDNA or integrated? And we really haven't taken that into account along the phases. So this individual was started on entecavir at a very young age with Kathy Schwartz, the pediatric hepatologist I had the pleasure of working with for many years, lost e antigen, developed anti-HBe. Currently has a no DNA detected, normal LT, and a relatively low surface antigen. We talked about this a bit in earlier sessions. Is it important to think about what's going on in the liver? How many hepatocytes are actually infected? Are we close to cure? Of those infected, how many have actively transcribed cccDNA? How many have silent cccDNA? And is this coming from integrated? The question came up earlier, and does it matter? And I would propose that it does matter, particularly if you're developing an antiviral drug for hepatitis B. You know, for example, a CAM is going to work potentially on cccDNA, but not integrated. Same with some of the other modalities as well. So this is a wonderful slide that Ashwin Balgopal, I have the pleasure of working with, along with Chloe Teal at Johns Hopkins, where they try to summarize some of the work that they and many others in the field have done looking at the liver. And essentially what they've described is a shift in the source of S antigen as an individual moves along that continuum from immune tolerant to functional cure. And I mentioned earlier in the Q&A session that in functional cure, it's not that we've eliminated all the infected hepatocytes. In fact, there must still be some infected hepatocytes or they wouldn't flare when we give them immunosuppressive therapy. But in general, what they're describing here is a shift from the source of S antigen from CCC to integrated, and along with that, a lowering of the HBV DNA. And we see that in patients followed over time. And in my practice, I certainly have people in their 70s not on nukes with very low DNA levels and very low S antigen levels. And I can envision in their livers that they have very minimal infection. So this, Jordan Feld showed some of the data from some of the studies that Chloe and Ashwin have performed, but I want to look at this one in some detail. What it shows, and these are people with HIV Hep B treated with nukes, and among those where most of the S antigen on intrahepatic analysis was coming from CCC, they did in fact have a pretty substantial drop in the amount of S antigen. That's over to the left. Not so much in those who were e antigen negative and had been nukes a long time. But what I wanted to focus on is all the way to the right. This is the analysis of infected hepatocytes and analyzing where the S antigen is coming from. So let's envision that these patients were going to stop the nuke therapy. I think we would predict that those in the bottom 2 rows, because you see a fairly large amount of cccDNA, at least from some hepatocytes, in actively transcription, that they would have viral rebound, that they would start to infect new hepatocytes and this process would begin. But if we look at the patient at the top, where it does appear the primary source of this very stable S antigen is coming from integrated, we might predict that this was a person that could safely stop nukes and maybe, if there is an immunologic response, eliminate that integrated S antigen. Now, of course, this is just a sample of the liver, it may not reflect, but the other thing they've shown is the number of hepatocytes decreased dramatically along this way. So I'll come to the issue of, so the question I'm asking with stopping is, if we envision getting to one of these endpoints defined by the US FDA of a sustained DNA suppression off treatment with or without S antigen, it really is going to depend on what that patient's liver looks like at the time we stop and whether or not there is an immune response. And I'm glad to see that Adam had no conclusions today, because I think that is my sense of this as well. What will it take to control the residual cccDNA in those patients the way we see in natural functional cure? So we could think about that as the potential likelihood of what will happen after we stop. If we've eliminated or completely silenced cccDNA, we should see no Hep B flare, no DNA flare, and no ALT flare. If it's partially reduced, perhaps we see that coming late. There's only a few hepatocytes left, they've got to reestablish infection, or if they're silenced, do they reactivate? And that might be prolonged, and Jordan Feld made this point. We did not plan that before I spoke today. The active transcription ongoing, they're going to flare pretty quickly. And I took the case example from Kash Agarwal from a patient treated in one of the clinical trials who had a very rapid reemergence of infection. So I think these patterns that we see can be explained in part by what's going on in the liver. So it would be great if we could study what's going on in the liver without doing a liver biopsy. I agree with Dr. Feld's point, and that made of our speakers, that patients will undergo liver biopsy in clinical protocols. There are many people with long-standing Hep B infection who are very interested in getting to a cure and want to contribute to that scientific advance. And I would submit that paired liver biopsy is a way that we can truly understand what's going on. But we do need peripheral markers. I was asked to focus on the bottom two, so I'm going to limit my comments to those. Hep B correlated antigen, which does reflect what's going on with cccDNA, both a pre-core and core component. And then I'll talk a bit more about core antigen only and phosphorylated Hep B core antigen, which really remove this part of pre-core and e antigen and may have greater utility. So when we think about correlated antigen, it is certainly derived from cccDNA transcription, but it's complicated. When we look at e antigen positive patients, the vast majority of this comes from hepatitis B e antigen, with some coming from the P22CR or pre-C and some reflecting core. As patients move along that pathway to e antigen negativity, we see lower expression of correlated antigen components, and that's something that affects, I think, the sensitivity of this. So when we look at hepatitis B virions, these contain only Hep B core and no pre-core proteins. There are also empty capsids and Hep B RNA particles. So I'll also highlight that these are very closely related. When we look at the figure down to the lower left, the phosphorylated hepatitis B core antigen really reflects this C terminal N, and this P core antigen is found in really empty particles, reflecting perhaps a different element of what we're seeing and maybe extending beyond what we see with suppression of intact virions. So it may be useful. I'll talk a little bit about that. So there was a really wonderful meta-analysis systematic review that helped me greatly in putting this talk together. I was one of the people asked to refresh my topics this year, and this was a new topic for me. So when we look at what correlated antigen levels mean, we certainly see, as I've alluded to, that they are lower as we progress from e antigen positivity to e antigen negativity, but they're also lower when patients progress from the hepatitis phase with elevated ALT and inflammation to the chronic infection phase. We see that continued decline, at least in some patients, particularly those who are e antigen negative in the bottom two rows. So what we're suggesting is the same thing that the biopsy data shows, that those patients have less cccDNA transcription, and that's certainly important. And in fact, when we look at detectability, we see the same pattern. This also, I think, really limits what we can tell from measuring correlated antigen in the blood. if we look at these patients who are negative, E antigen negative infection and E antigen negative eventually losing, many of them are undetectable using traditional assays. So in a sense, does this mean they're not replicating or they're not producing or transcribing cccDNA? I think the answer is no. We know that from the paired biopsies in these patients. We know that also from clinical experience. But it does predict the eventual loss. And you can see in the column all the way to the right that when they looked at whether or not these individuals were DNA positive, they in fact were. So here, correlated antigen is not telling us all we need to know about cccDNA transcription. A really fascinating paper kind of looks at this natural history, and this is what we see in clinic. It's what I describe with my patient. This individual is moving along this spectrum, maybe moving a little quicker because she started the nuke at age 3. Whereas these are largely untreated patients, many of them did get treated eventually. But what they show is that the correlated antigen first becomes undetectable, suggesting that shift has occurred with less transcription, less infected hepatocytes, and then eventually they clear, some of them, not all, 10 to 13 years later, their residual infected hepatocytes. We would suspect that's the immune system, but it's really hard to know what's going on. And clearly, when we look at this figure, what we want to do is accelerate this. We don't want to wait 10 to 13 years. That's a very difficult timeline for antiviral drug development. But we do want to accelerate this loss of S antigen, moving people to the younger age. And I would suggest that maybe the patient I described at age 28 is a lot closer because we stopped viral replication to the extent possible with an oral nucleotide or nucleoside analog. So, and certainly this, to follow that study further, does show that correlated antigen predicts the potential for S antigen loss. I think that's been reasonably well established, and combining that with S antigen levels can be helpful, although as our first lecture of the day really demonstrates, S antigen levels do predict S antigen loss. It's a bit circular, but remains true. So I think correlated antigen may add to this in terms of predicting S antigen clearance, both if stopping nukes as well with therapy. So in a sense, it is an important thing to measure. If you're starting a clinical trial or starting to treat a patient, really asking the question, how much cccDNA transcription is here? An estimate of how many hepatocytes are infected actively. You can get that from DNA, certainly. Patients with lower DNA have lower infected hepatocytes. You may also get that from correlated antigen. But one of the questions, I think, is this lack of performance, if you will, entirely because it's not good enough. I'll go back to a study that I did, had a chance to be part of a number of years ago with MF, who's here in the audience, and will speak later. These were patients treated with an early first-generation CAM and nucleoside analogs. And we made the decision to stop therapy in 43 of these patients. I won't go into the details of this, but I do want to highlight that all patients experience a DNA relapse. So let's say we had made a decision to stop based on correlated antigen. In the E antigen positive patients of panel A, well, you probably would have predicted they all would relapse since none of the people here were not detected for correlated antigen using the standard assay. But let's look at the antigen negative. 10 were not detectable by that assay. So maybe they were the 10 who would go on to achieve a functional cure. They were not, because this did not truly tell us what was going on in the liver of those patients. They had replication-competent cccDNA. So what about higher sensitivity hepatitis B correlated antigen assays? You saw a slide earlier on this. There is a more sensitive assay that's referred to as ITAC here that's about a 10-fold greater sensitivity and did appear to predict the likelihood of hep B reactivation in a small sample of patients. They detected empty particles earlier before they detected intact virions. Sort of an interesting concept of how that occurred. And they did demonstrate that in some of those people who were undetectable, they were able to identify correlated antigen. So perhaps this is useful in applying to patients. And then moving to talk about hepatitis B correlated antigen-specific immunoassays, I want to thank Gavin Cloherty for sharing some of these slides. But they have developed an immunoassay to detect non-phosphorylated and phosphorylated hepatitis B core antigen specifically for research use only at this juncture. And when we think about what we're seeing here, Core antigen is only from cccDNA, and it's not impacted by pre-core mutations, which is one of the problems, one of the reasons why you see that the movement of core levels across the spectrum. And here, the phosphorylated core antigen reflects empty capsids, where core antigen is in DNA-containing capsids. And what they demonstrate on the top upper left is increased sensitivity compared to correlated antigen, and particularly if you look at the lower limb of detection, potentially a more sensitive assay. These correlate quite well to the lower right, the P core antigen and the standard hepatitis B core antigen correlate to the lower right, and there's no cross-reactivity with E antigen, suggesting the potential for increased performance. Now, what they did in this paper published in Journal of Clinical Virology in 2023 was took Replicore data. These are patients who achieved a response after treatment with triple therapy, a nuke, interferon, as well as nucleic acid polymer. And what they demonstrate is this decline initially of the correlated antigen, reflecting DNA-containing particles, a rapid decrease with starting of nukes, as one might expect, and then they show a slower phosphorylated hepatitis B correlated antigen level during the interferon and nucleic acid phase, indicating that these individuals, although we're seeing the core antigen come down, they're still transcribing cccDNA, and that must be essential if we're going to get to a functional cure. So this is obviously very preliminary data, and we need more information, but suggests it may be more useful, both with greater sensitivity, but also greater specificity for what we're measuring. I want to come back to the liver biopsy. The one important, I think, finding here, and this is from the Janssen Insight study, and Jordan already referred to this, there's identification of what I'll call cured hepatocytes that appear to have no cccDNA detected, and their hepatitis B RNA negative. So that's great. They need to be cured. And over to the right, you see these non-infected hepatocytes going up dramatically, really in both groups, less in E antigen positive patients. But then you also see this silencing. And here, the way this was defined is cccDNA is detected, but no episomal hepatitis B RNA. So the idea is that cccDNA is there, but it's turned off, at least to the level we can detect it using the assays used. And siRNA therapy did both. It cured hepatocytes, but it also created some silent hepatocytes with major differences in E antigen positive and E antigen negative patients over to the left. And that's to be expected since we have really established that these E antigen negative patients have a different degree of infection in terms of the number of infected hepatocytes and the number with cccDNA that's active. But I want to think about these silent hepatocytes as we think about stopping therapy. Can they turn back on? So if all you've done is induced more silencing with an antiviral or some other mechanism to interfere with viral replication, you've induced silencing. I don't understand how that happens, and I think that's an area we need to have more research. But if you didn't change the immunologic profile of that patient, what is to prevent the reactivation of active transcription in those silent hepatocytes? Once you remove the siRNA, will they come back? And I don't think we quite know the answer to that, but it does highlight the potential role of the immune system. So I wanted to highlight at least one study that looked at one measure of immunity. That was the increase in anti-HBs. And in this particular study of interferon and nucleic acid treated, nucleoside analog treated patients, there were 80 patients, some of whom developed a sustained hepatitis B antigen loss, 21 of them. And in the figures, what it demonstrates is there was a predictive value of the amount of correlated antigen and the titer of anti-HBs. So those two were relatively predicted. Now, I'll give you the caveat that these are very small sample sizes. In addition, they had higher markers of cellular and human immunity. I won't go into that data at the end of follow-up, suggesting that one of the key elements of sustained silencing, because after all, functional cure by definition means there are silent cccDNA infected hepatocytes. It doesn't mean we cured them. So the humoral immunity is necessary, and interferon in this case, and I agree with some comments made earlier, interferon is more than an immunologic agent. There are also very pleiotropic effects on viral replication, but it does suggest that the immune system may play a role in this. So to summarize some of the things that I've talked about, would increased sensitivity help and improve utility? Well, I'll start with the first bullet point, that we absolutely need better peripheral markers of cccDNA transcriptional activity. I think we also need to start thinking about the patients we're enrolling in clinical trials and treating in practice, not just based on where their peripheral markers are, but what they're telling us about the infection in their liver and what they're telling us about how close they are to control that infection. So I think that there's certainly no question that a higher sensitivity correlated antigen may be useful in predicting patients who will lose S antigen and reactivation risk. I think there may be improved if we combine those. But I think the lack of specificity for core will always limit the value of correlated antigen, and these are going to be lower in people who are e antigen negative. We spent a lot of time talking about those today, and many of the patients we see have that. So I do think there is a role for specific Hep B core antigen and phosphorylated hepatitis B core. I think these are promising. More research is needed, and the inclusion of these into clinical trials is certainly important. But it also suggests that perhaps we can't get there by peripheral measurements of cccDNA transcriptional activity, or more importantly, the potential, because those silent hepatocytes, the ones with cccDNA that's not being transcribed, you won't measure core antigen in the blood or any marker if that's truly the case, and they could still flare after stopping or fail to achieve a functional cure. So it does, I think, highlight that in the natural state, it's a combination of both eliminating infected hepatocytes, the number with cccDNA falls over time, but it's also an increase in immune control. And I think that's something we need to consider, but I think it's also going to continue to limit the value of these markers. So I'll stop there. Thank you for your attention.